Rising Practices and Policies Revisited, Emerging Priorities in Mental Health and School Mental Health. So we are at session 1 today for our upcoming sessions. So we're also going to be providing a session on supporting refugees and asylees from war. We're going to be presenting a session on working with youth and families experiencing homelessness and home insecurity. I know that's a big issue that comes through really frequently in our evaluation forms, a great area of need. And then we're going to do a final session on the mental health and student mental health workforce. We're calling it the woes and wonders of recruitment and retention. All right, so why are we here? Well, we are here because we have brought together an absolutely amazing group of regional leaders who know 988 inside and out, warts and wonders, and they came and talked to all of us last year, led some great sessions, like, you know, when it first happened, what was it going to be like? What did we predict? What was going to be a challenge? And now we're here to talk about how year 1 went. So here on the first birthday of 988, we're going to talk about what kinds of factors or policies or people have supported the rollout of 988. We're going to talk about some of the challenges and also some of the wins. And then we're going to offer some lessons learned. So, you know, there are things that worked and things that didn't work. I often remind my teams that we learn as much from the things we tried that didn't work as the ones that we tried that did work, even though they are significantly more frustrating. So yeah, so we're going to hear about emerging practices, and so we've got today's presenters.
Today we're here to listen to some regional leaders share their opportunities and challenges through systems transitions. Some of you may be completely new to 988, and some of you may be more advanced in your understanding around 988 and all the things that have happened in the past year. Whatever level you are at today, we really want to engage everyone in conversation. So we encourage you to ask questions, offer your own resources, and know that this is just the start of our Regions 988 support, because there is so much more we can get done in 75 minutes. Our panel will explain much more about 988 and its implementation promises and challenges. Briefly, we'll talk a little bit about 988 just before we start. So 988, what is it? On July 16, 2022, a 3-digit national mental health crisis hotline mandated by the federal government in October of 2020 launched nationwide, where people can call, text, or chat through this hotline. They are connected to trained counselors that are part of the existing referral pathway, the crisis continuum, and other national suicide prevention lifeline networks. The expansion of the current National Suicide Prevention Lifeline program effectively triages and responds to stabilize individuals experiencing a mental health crisis, requires significant workforce expansion and training. That is the idea for 988. So we're going to go ahead and bring our region's incredible leaders, and I'm going to introduce them to you now. We're going to talk more about the expansion of 988. Today we have David Eric Lopez, who is the program manager at the Kingsview Central Valley Suicide Prevention Hotline. We have worked with David before, and he has amazing knowledge and expertise around crisis care and suicide prevention, and is in the trenches on the 988 work. We also have CJ LaSalle, who is the Division of Grants and Innovation at Arizona Healthcare Cost Containment Center, the Deputy Assistant Director there. Carrie Marshall, MSW, Social Entrepreneurs President, and Margie Balfour, PhD, the Chief of Quality and Clinical Intervention at Connections Health Solutions. Our panelists here today, as you can see, they're very rich in diversity, and they come from different roles across the county and state private systems. We are really pleased to have all 4 of them here to offer their viewpoints and their experiences. We are thrilled that the same speakers from last year were able to return this year, so they get to reflect on what the year has actually been like for them. That is really exciting. We will, like Miranda mentioned, we will have a very dedicated Q&A session as well as an after party for those of you who are available to join. So we'll go ahead and get started with the presentations, and let's start with David.
So that's a picture of me, and that was in 2018. This was actually taken in DC, and I was attending the American Association of Suicidology conference. This was where the rally happened on Capitol Hill, and I happened to be privileged enough to be there for that conference and attend that hill. Since 2018, I joined the Lifeline, probably 2017 is when I took over, and I've seen tremendous growth. So what I really want to just highlight is, hey, I remember here this beginning point of 2018. I'm going to talk to you a little bit about where we're at, what we've seen, and then just like everyone mentioned, I hope to just share some knowledge with you today. Okay, so as Danielle had interluded, it's like, why 988? Well, part of the biggest things is, hey, being able to connect to someone in when you're in a crisis, right? No matter what time of day or night. And traditionally, when you look at the service providers or services that have been out there in the community, not everything was 24/7. So the Lifeline was established many years ago. That when we launched 988, the goal was to have a new front-facing number for the country to see. That way it could start being marketed and start highlighting so people would have an easy to remember number that they could use when they were either in a mental health crisis, a substance use crisis, or a substance use crisis, suicidal crisis and substance use crisis. And anyone could call at any given time, and that's really the beauty and the power behind 988 or the Lifeline itself, and the Lifeline itself is that it's free and accessible to the end user, and we are available 24/7. So one of the goals is, and when we launched on that July 16th, we were all the 13, was originally 13 call centers, but call center in California, now it's 12, but call centers nationwide, we're really gearing up and ramping up towards this. And we really wanted to be able that we could meet the needs of the potential call surge or volumes. And so why is it there? It's for an individual to connect to that trained person. We really wanted to improve the immediate service to those who are in a crisis. That way, when they reach out, they can actually be trained with an actual suicide prevention and crisis counselor the first time, instead of being, potentially diverted to 911, where they don't have the same resources, again, the mobile crisis units and stuff weren't really stood up at that time. One of the big visions behind 988 and what we've seen so far is really helping to reduce the stigma and prejudice around those who are seeking help. And one of the big goals and things that we're starting to work on, we've already established some, is that increased collaboration between 911 and 988. And that is, so when someone calls 911, and if that person would be better suited to actually talking to a trained counselor, a lot of the different crisis centers across the state and hopefully across the nation, this is some of our directives, would sign like different MOUs, memorandums of understanding, so the 911 center could send that call to us. That way a counselor could work with that individual at that time to help get them that appropriate support when needed. So here is a look of the 988 crisis centers in California. Now, I'm happy to say that all 12 call centers in California or crisis centers work really collaboratively with this rollout. We have, about the previous 18 months before the launch of 988, really started working as a consortium and a collaborative approach to how we can better address the needs of our unique regions and the potential increase of call volumes. So understanding that California is such a big state, and there's so many different communities, and every county and community is very different. And so we want to respect all of that. So this was just a map to show that the different regions and the call centers that they cover. Mine happens to be in the middle, which is the Central Valley, that dark purple right there. And that's the region which we cover several counties. But I just wanted to highlight here that it's a very collaborative approach for all of us. So what's been working? Well, I can say that we have had, through some funding that was granted by the state and the government, an ability to increase the capacity to support the services that and the volumes that we see. So we hired, my team doubled in size, and most teams across the the state did. And I know there was additional funding across the nation. I hope that everyone got what they needed. I'm really speaking specifically to our California centers at this moment. We all offer additional services, and they're really amplifying the amounts of follow-up and text and chat services. We were not a text and chat service center. Now we are. As I mentioned, that follow-up program is now being increased and uplifted to help when someone is either discharged or when we feel that individual could continue to be serviced with a follow-up call, and then after they've been de-escalated, we do that. A big thing is the increase in training that we can provide to our counselors prior to staffing the lines. Every single one of the crisis line centers is accredited by one of two bodies. Ours is accredited by the American Association of Suicidology. And really that increased support to frontline counselors comes from the increased staff leads or team leads that we have on the floor to help support them when they're doing that work. The increase of quality reviews, which helps us promote better quality of contacts. We really want to give that real-time feedback as quickly as possible, and that increase to outreach throughout the communities. So areas of growth. Here's something that unfortunately we have seen. A lot of people still may not know what 988 is, and potentially that's a twofold process. One, the big campaign when 988 rolled out wasn't really promoted as much as we would have liked, and as far as California, it was more strategic positioning because not all call centers were in the same place to potentially receive that call volume. And the last thing we wanted to do was not promote this service and not be able to deliver the service that we had. So now that we're beyond that phase and we have increased our capacity, we really hope to promote this out to the community and make people more aware of what 988 is and the services it can provide. We haven't seen a lot of social media presence, and we definitely want to increase that. Another big area of growth is the increase of shared resources for in-service areas and also across the country, or at least our neighboring areas. That would be good. A big thing that 988 wants to promote is just additional trainings or things that we can do to help increase our bandwidth of what we would call like the different type of screener type trainings, like what you call QPR, question, persuade, refer, assist 11, these types of trainings to help increase our surveillance in the community, and then definitely increase collaboration between 988 and mobile crisis units teams. We have some good collaboration right now internally, but we're still working towards getting that part up and going. Next slide, please. And then again, lessons learned, as I just mentioned, many people are still unaware of 988. We still struggle to hire. So many people capable and willing across the state varies. We do know that when 988 is utilized, and this is coming off the Lifeline itself, over 96% of calls are served without needing additional interventions. And we're definitely wanting to get more people involved in increase of those mobile crisis units. So that's kind of where we're at right now. So the long-term vision of 988, the sturdy three-legged stool. Again, this is someone to call, being the 988 centers, someone to respond. This would be the mobile crisis units, and a safe place to go. This could either be warm locations or the increase of crisis stabilization units across the state. One thing with the 911 right now is being operated by a system called NGA that all California centers will be on through NGA 988. That's the service provider, and that's really going to help the interconnectability between all resource centers and public service crisis times, and then an enhanced crisis continuum of care for services.
Thank you so much, David. How exciting that you were there from the beginning, and thank you for sharing the photo. And your experience and thoughts around what's next and how we can better address the needs with the 988 rollout. I really admire the work your team is doing, especially in the community, to raise awareness and just create more transparency around available services. Thank you. Next, we have CJ, who's the Deputy Assistant Director at the Division of Grants and Innovation with the Arizona Healthcare Cost Containment Systems.
So here in Arizona, we have been working for over 3 decades on building a crisis continuum. And so I kind of wanted just to highlight the funding stream and how this works when you incorporate 988. So because 988 is built on the old National Suicide Prevention Lifeline Network, it is funded directly from SAMHSA through Vibrant and then trickles down to the Lifeline centers. In Arizona, our longstanding robust crisis system actually is funded through braided funding. We use Medicaid dollars, we use grant dollars, we use state appropriation dollars, and we pass all of these funds through managed care organizations that have regional behavioral health agreements with Access, the state Medicaid agency. And we require that our REVA operated, we call it REVAs, our managed care organizations ensure that all crisis services are operated under what we call a no wrong door policy. In order to do that, we have to use this unique funding so that the service can be provided, whether it's the call or the mobile team, stabilization facility, or whatever a person needs can be funded. And then we can figure out who their insurance coverage needs to be or who's going to pay the bill later. Most importantly, that immediate contact and immediate intervention to help resolve the crisis. So because of that, Arizona decided not to simply adopt 988 and do away with our existing infrastructure, but rather to integrate the 988 system into our existing infrastructure. We did that with some changes to our contract language and some requirements. The biggest one being that our managed care organizations needed to partner with existing Lifeline centers to operate our call centers for our regular crisis system. What this does is it really brings everybody into the same place, which means for Arizona, it doesn't matter what number you call. Those old ones that have been around and in those little cards in our back pockets and on our refrigerators for over 30 years, or the new 988 number, you're going to get that same connection, that same quality counseling service that anybody would get calling 988 or our 10-digit numbers here. And you're also going to be able to connect directly to a mobile team if you need it. Our Lifeline centers and call centers do all of the mobile team dispatching here in Arizona. So as soon as a counselor identifies that a person might need a physical person to respond and help them, they are able to pass off the request for a dispatch to someone else and continue to engage with the person on the phone and let them know that someone's on their way. We've found this to be very effective in Arizona. So that's why rather than some states where they have multiple call centers, we really wanted this partnership, and our partners at Solari and La Frontera joined in a formal partnership to make sure that they were all operating under that same electronic health record and call system and could connect to those dispatchers if needed. They also can coordinate with our crisis stabilization facilities and say, hey, I'm talking with CJ right now. I'm going to send her over to you. Here's what's going on. And that coordination has really shown some great outcomes. And if a person's already experiencing the worst day of their life, having to repeat what they've been through over and over and over can be re-traumatizing. And so in collecting all of these services and coordination into one spot, we're able to reduce that re-traumatization during a crisis episode. So this is what our crisis hub model looks like. As you can see, that phone is in the middle. It is the least restricted, least invasive, and most easily trusted piece of our crisis care continuum. But it requires support. It requires those additional pieces to connect, take care if a person needs it. We also need that coordination with state partners like our 911 dispatch centers and our police officers that are out in the field, and they're out there in the community. They're the first ones to respond to emergencies. And we've done a great job here in Arizona working with our system partners and doing CIT training for police officers and giving them specialized phone numbers to contact our crisis system so that a mobile team can come relieve them when they do just happen upon an incident in the community that would be better served by behavioral health. There's been a lot of work being done, especially since the launch of 988, but over the years in Arizona to partner with our 911 public safety answering points. We call them PSAPs because we like to put acronyms on everything. But there is still, 30, 40, 50 years of protocols and routine and trust that our 911 dispatchers rely on. So our team at Access and at our managed care organizations and even on the provider network have really done a lot of work in building relationships with the folks answering the phone at 911 to help train them. We have co-locations where we have a 988 or crisis counselor actually working at the public safety answering point where they can help a dispatcher, they can listen in on calls, they can take calls over. We have virtual co-locations where calls might just be discussed in a virtual platform and then maybe transferred. But it is still tough. And so our motto there really has been, we want to be the fourth option. So when 911 gets a call, if they are able to, if they're trained and they trust our system and they're able to say, this would be best addressed by the crisis system rather than an ambulance, a fire truck, or a police officer, that those calls come to us and we get that person to the appropriate care and treatment that they need, and eliminate and lower the involvement of law enforcement in crisis interaction. So just basic picture of what that hub model looks like. So with over the last year with 988, as I mentioned, we didn't just adopt it, we kept our system going. We did that because of trust and utilization. Our call centers respond to about 40,000 crisis calls in our established crisis continuum, only around 5,000 calls a month that are coming through 988. Some of those challenges has just been timing. Arizona residents have had very, very, very long-standing relationships with those call centers that we have established, and those calls are live answered. So just the time it takes to get from the voice recording and answer on 988 to a person has been frustrated. But we're still breaking that stigma. We're still not able to respond locally to texts and chats. We're hoping that SAMHSA and Vibrant will get that worked out. They're in a phased approach to do that. And we're still looking at how can we really evaluate the quality of service and make sure that response is equitable for anyone who calls and tailored for special different needs, people living with intellectual and developmental disabilities and so on. And also continuing to build partnerships with first responders. As I said, we want to be that fourth responder, and looking at our state policies and building relationships there to support 988. Those are our next steps and our ongoing efforts that we've been doing over this year.
Thank you so much, CJ. I really appreciated the way you highlighted the Arizona crisis call funding streams. Super informative, and especially as many programs are trying to look for ways to braid funding here in California for increased capacity. That was really great to see. And 3 decades is really amazing. Kudos to your program and all the things you're doing. Your work in developing partnerships is really admirable, especially, it really speaks to the national guidelines around best practices for crisis response and really working for crisis response to be, from the first lens of a least restrictive intervention as possible. So kudos to you. Our next presenter, Kelly Marshall, MSW, social entrepreneur, and is the president.
So I'm going to start with some updates. I think just to frame things, I represent Nevada, so I was part of the team that wrote the implementation plan for Nevada. Nevada's system is a statewide call center and then linked to regional behavioral health entities. And so we have 17 counties, unlike the 58 counties in California. It was thought that it would be manageable to approach a statewide system, and we had a statewide lifeline that was also a national backup center, who currently is the vendor. So our rollout is statewide. I also am leading a project to implement in one of the regions. So I'm going to weave in both some regional and some state intel for you all. So this is really similar to what you heard from David and CJ. Everything is about communication, which is not surprising when you think about a call center, right? Communication is key. And so one of the things that's been really great is that there has been clear communication, and that we worked with a planning coalition from way before implementation, so more than 2 years ago. And that planning coalition is still in existence and continues to meet. So we have the right partners at the table. We've been able to kind of cultivate those relationships over time. They understand their role. And we also have focused funding. And so I wanted to kind of link to the next little block to say that Nevada is one of 5 states that actually passed legislation to issue a surcharge on phone lines, both landlines and cell phones, that then goes into a crisis response fund that can help stand up and build the crisis response system. So that's really a positive. That fund has been established and the regulations are just about to be adopted to start collecting the fees. So similar to what CJ was saying, we also have braided funding. So multiple funding streams, both at the federal level, the state level, and the local level, regional level, are supporting the rollout. And as I mentioned, that planning coalition, so the state is the entity that is leading implementation. We've got regional partners doing regional work, but they then work with this planning coalition, and the planning coalition helped write the implementation plan. So that allows for some continuity and accountability for saying, okay, well, we said we were going to do this. What's the status of it? And that doesn't mean that the status of it is, oh yeah, we did it. Sometimes it's, oh, we hit these roadblocks, but there's clear communication about that. So that leads to some good community support and buy-in, particularly through those partners on the planning coalition. So we can go to the next slide. All right, so what are some of the wins? Well, tackling the entire crisis response system. So we did all 3 rungs of the stool, legs of the stool that David was mentioning. We decided to build them all at the same time using the framework of these national guidelines that have been published. What's interesting about that is that we kept waiting and waiting for the children's guidelines to come, and they finally were published after we did our plan. So I'll talk more about that in a minute. We've got a request for information and a request for proposal process underway for a big technology upgrade, which would be a call center hub that links those 3 legs of the stool. And we have a new governor. So our old governor was supporting this. Our new governor is also still supporting this, and our legislature is supporting this. Unfortunately, they have 2 competing bills in the legislature right now about implementation. So we're waiting to see how that kind of shakes out. So the public and policy members continue to support, and right now there's a lot of I guess, excitement and engagement around those 2 pieces of legislation. Both are supportive of implementing the entire crisis response system. They just take different approaches to doing it. And we've got law enforcement advocates, providers, people with lived experience. We also have the managed care companies and affiliate groups that many of the people with lived experience are part of, collaborating on the implementation. So those are some of the wins that we have. As I said, regional implementations underway, so we're excited about that. The picture on the right is actually a design for the regional implementation based on one of the 5 behavioral health regions. And so they've established a partner agency team that includes all those providers. And then they have a coordination and accountability team that focuses more on the policies and looks at the data. And that tends to be like the elected officials, the payers, the hospitals, and then we have a linkage with the state. So the state that's managing the statewide implementation is part of that. So they're like the policy side. And then the partner agency team, they're talking about things like, this person fell through the cracks. Like, we were trying to pass somebody off to you or hand somebody off warmly to you. That didn't work. And they're actually dealing with things like protocols. And as David mentioned, memorandums of understanding and ensuring that like the systems are in place for implementation. That's happening at a regional level. At the state level, the state got a Medicaid mobile crisis planning grant. And so they're just about to set the rates for mobile crisis, but that has delayed mobile crisis and the funding of mobile crisis teams and what we're calling designated mobile crisis teams. We have a lot of co-responder models where we have law enforcement plus a clinician, but we're looking for those teams where it's not law enforcement based, where it's a clinician and a peer. We really think that peers are part of the future of standing up 988 and the crisis response system. So that's a wait right now. We also have funding set aside for crisis stabilization units, and that's working through a regulatory process to figure out, do they have to be a hospital? If they're not a hospital, what are the regulations we're going to accredit them under? So there's a little bit of impatience, I would say, statewide with the bureaucracy. People want to see the funding reach the providers, but they have to wait for the regulations to be adopted. And one of the other pieces that's kind of concerning in Nevada, we don't have 12 across the state. We have one statewide center. Similar to what was described previously, we got an influx of money to hire people. People had to be hired and trained. The same folks that do the call center are not always the best people to answer chats. And so there's different training curriculum needed for those different skill sets. And you don't always know when you hire somebody, oh, are they going to be best at chat or are they going to be best on the call? And the idea of like cross-training them, which is what we initially thought was determined to be a bad idea, that some people are really just better at chat or text. And so it's broken out that way. We have call takers and then we have chat and text takers. But as a result of that, our answer rate, our response rate for picking up the phone has been slower as we've onboarded people, figured out what seat on the bus they sit best in. And so that hiring and training to create a workforce pipeline takes time. So my key takeaways, as I mentioned, the children's crisis system, and those guidelines came into place. One of our things is we need to continue to convene and communicate with people, even when things don't go as planned, such as the regulations. That's been really critical as we now build out the children's system and try to acknowledge that, you know, children are not just small adults, and there are some parts of the system and the guidelines that are really different. And so we're kind of engaging in additional planning around that. I already mentioned the use of peers being so important, and then incorporating those existing co-responder model teams into the process those are kind of some of the important next steps for us.
Thank you so much, Kelly. Thank you for highlighting some really important things in regards to your planning coalition and all the work there, and that key stakeholder engagement. It's so crucial when, you know, considering community needs. And thank you so much for sharing all your wins and challenges, especially the policy level challenges. I think that hits home for a lot of folks here in the room, especially me, myself. I know we come across those challenges and it can be tough. And also just your takeaway around the children's crisis system and how, you know, as we build out this system and we offer crisis services, that we really need to come from a lens of this type of work is different when working with children. And, you know, it can be harder or more challenging, and we really need to make sure we focus there. And next we have Margie Balfour, the Chief of Quality and Clinical Innovation at Connections Health Solutions. Go ahead and take it away, Margie.
I'm Margie Balfour, I'm a psychiatrist with Connections Health Solutions, and we operate crisis centers. So we're that third leg of the stool, a safe place to go. And between our two centers in Arizona, one in Phoenix, one in Tucson, we see about 35,000 crisis visits a year. about half of which come directly from law enforcement, and about 2,200 of which are youth. And we, as CJ said, we've had a very robust crisis system in Arizona for a very long time. We are currently have projects underway in a couple of other states, and I do a lot of national work as well. And as this crisis field is developing, we're starting to see, we really are starting to start to define crisis services in a way, or needing to in a way that's kind of more rigorous than has been done before. So I'm going to talk a little bit about that. So as CJ mentioned, we've got a single consolidated crisis line for the whole state. And what is kind of evolving is how they interact with 911 is kind of evolving into different models. And there really is no one size fits all approach, but the ultimate goal is that we want, we've got the national number, the 988 number that people can remember, easy to remember, so people can call that. We've got our local crisis numbers, but there's always going to be people who call 911. And it's so important for however you get to the crisis line, for that crisis line to have access to local resources like mobile crisis and facilities and things like that to get people connected to the right care. And what's kind of happening is there's all these, there's like 9,000 PSAPs across the US. So there's like 9,000 experiments on how best to do this happening across the country. We have 81 in Arizona. And what's kind of evolved is that you've got different levels of how those, the crisis line is interfacing with each individual PSAP. And so all the way from coordinated, where there's protocols and training, and usually a kind of, I call it like the secret backdoor number for the crisis line staff to be able to transfer a call to or for 911 staff to be able to identify a call as behavioral health and then do a warm transfer of that call over to the crisis line in wherever their offsite center is. Then there's co-located, where some of the centers in Arizona, the Solari staff are on site, and they're providing training and real-time coaching of, hey, that's a call that would be good to send over to the crisis line. And then they're able to get those transferred. All the way to what's in our Tucson center is more of an integrated model, where there's actually crisis line staff that are on site and sit shoulder to shoulder with the 911 call takers, are able to have full access to their computerized dispatch system, and clear calls the 911 system and take those there. There's really no consensus on, is one better than the other, or is one more suited for certain types of setting, so rural versus urban, or what crisis services are available. So we actually have a research grant from the National Institute of Justice to start to study some of the differences in these models. And what we're finding so far, we're just in the mapping session, and that section where we're just trying to map out how the protocols work. And it's a lot more complicated than it might just look on, on a nice schematic like this, and that every different piece of the system may know their part really well, but then once it's sort of transferred outside their realm, it's like, and then I don't know what happens after that. And so even just mapping that out has been an interesting process. Another area where I think they're really, we're seeing that there's really a need for standardization is the facilities themselves. And so I actually, and I was writing a paper recently, and I made the statement that the term crisis stabilization unit is pretty much meaningless these days, because people use that term to describe such a broad range of facilities that we really need a way to start to classify these facilities for a variety of reasons. One is so that we are matching people, the people in need of care, to the right intensity and safety level of service that can meet their needs, but also so that we can do planning to make sure that there's facilities that can take care of all different levels of acuity, kind of like how for medical issues, when we all know the difference, there's level 1, 2, 3 trauma centers, there's critical access hospitals that are for more rural areas that, maybe paid a little bit differently because that's such an important service. And we don't have anything like that right now for crisis centers. And like you were just mentioning before with like the licensure at the state level, every single state, if, unless you're like state like Arizona that's had crisis centers for a long time, there's often not even state regs for these things. And so people are trying to sort of shoehorn them into existing regs. So this is something we put together recently, where just started to try to map out, well, all these facilities that exist and they're calling themselves whatever they call themselves, can we start to try to line them up into some buckets? And so on the left are the high acuity, high intensity programs that can take that's kind of where we fit in at Connections, where we take the highly agitated, highly acute, can be intoxicated, where you need 24/7 medical and nursing capability, all the way to the other end of the spectrum, which is just as important, is you need the more like a living room for the lower people who don't need all of that. It would be overkill to have them in a facility like that, and they probably wouldn't have a very good experience if they don't need that level of intensity. So those are things like respite and living rooms and things like that. And then you've got the places in the middle, and that's where it can be, if you're not careful and people don't have a clear understanding of what are the types of services available there, what's the level of intensity, and what's the level of acuity of patients that you can care for, you can get into some dangerous situations, or you could end up building crisis services that leave out services for the most in needs people. Like, for example, if a community builds a center that only takes voluntary people, and then the involuntary people still have to go to the emergency room and board, then you've actually left out the most in need of services. And when it comes to what happens after the call, there's a lot of talk around co-responders. And in Tucson, we've had such a long-standing development of the crisis system, and also a really progressive police department. We've really evolved into what we like to call a collaborative model versus a co-responder model, because as you have more options, then you're able to tailor what that collaboration looks like to the individual situation. So if you kind of think about, what you want is, as much as possible, you want what we call a health first response, where it's clinical people responding with law enforcement there only if absolutely necessary. And another thing that we often forget around crisis is we focus a lot on the acute crisis, but then as that crisis is resolving, there's work to be done to make sure that the people get connected to where they need to be. And then as a crisis is developing, there may be opportunity for outreach and prevention. So that's that blue side of the cycle there, because if you don't do those things, you're just going to have a repeat of crisis. So if you think about, you've got the urgency of the crisis and then the safety risk, you can sort of plot them on this schematic here, where if something, when you're in the acute phase, that's when you have a discrete event, you need an intervention, it's urgent, it needs to happen fast. And if there's not a safety issue, then that should completely be the responsibility of the mental health system. Law enforcement shouldn't be involved. And so that's where our three-legged stool is. I mean, that's 988, mobile crisis teams and crisis facilities. And in Arizona, we have a lot of, I think Pima County has like 16 mobile crisis teams that are a mix of clinicians and peers that cover the whole county, and so that you can get a clinical only response if you need to. And then if there is a safety issue, then that's where you want to collaborate. So sometimes the fastest thing is to send a CIT trained officer to pick someone up and take them to the crisis center. Sometimes if the police are on scene, like trying to negotiate getting someone to come out of their house, they may ask the mobile team to come assist them. So what that collaboration may look different depending on the situation. And then on the blue side, that's same thing, where there's opportunity for outreach and follow-up, but if there's not any safety issues, then that's the mental health system's responsibility. But if there are, we've got multiple co-responder teams where peers go out with the officers to do that outreach and follow-up. And then just to wrap up, my recommendations is, 988 is just the first step in getting to this health first response. And it's critical that we are able to connect those callers to local resources, especially as communities are developing more and more robust services. And that area code routing issue, I think, will be a huge piece in helping ensure that. And then we need, like I said, we need to develop standards, and just wanted to call your attention to a new resource that we just announced at the National Council meeting last week. I'm part of the Medical Directors Institute, where we put out a schematic or framework for, given that communities are in different stages of development, we put our framework to help communities develop outcome measures that work for them and for where they are and what their priorities are at the given moment.
Thank you so much, Margie. I really love the way you emphasize there really is no one size fits all approach in crisis services or in crisis in general. It's extremely complex world, which naturally makes our systems really complex. And I like that approach of different solutions for different situations. And really what you said about matching people in need of care and matching them to the right place based off their needs, and really making sure not to leave anyone out during the process. You hit it really well when you said, when we focus on crisis stabilization units or only focusing on really just trying to resolve the crisis, and that's the main focus, which it should be, but we may unintentionally leave others out who need a higher level of care. So great points. Thank you so much. What are the two pieces of competing legislation that you mentioned?
Well, thanks, Pat, for your question. I'm going to try not to get too policy wonky here. So initially, we had a legislator introduce a bill that included what they call cleanup language. So they had done public workshops with the telecoms to get a reaction to the legislation. And they had some concerns about definitions of like landline and mobile line. And again, I don't want to get into too much detail, but it was things like, if I have a fax number, I don't want to have to pay this tax on a fax number or pay this fee on a fax line that's a dedicated fax line. And so they did some cleanup stuff. So in the course of doing that, they also designated who would oversee the fee and the fund. And then, as I mentioned, we have a new governor as of January, after the November election. And his chief of staff actually was a co-sponsor on the legislation. So he suggested that they should introduce their own legislation. So I think they both wanted to improve and make sure that the language is clear. Right now, they're kind of in a standoff because we have a Democratic held legislature, and our major executive branch person, our governor, is a Republican. And so the bills are kind of both in this sort of standoff with each other about how they're going to move things forward. So I can pull out what the bill numbers are and pull them for you when I'm not talking. So I'll put that in the chat in a moment. But in essence, they're both trying to stand up this ongoing funding stream for crisis response. They're just not exactly in agreement about the details. So it's a process, and we'll see how it all turns out in June when our legislature ends its session.
Part of your funding comes from a tax on telephone lines.
Thanks for the question. Nevada's legislature meets every 2 years. And so as 988 was getting ready to go live, there was a real sense of urgency. At the national level, Vibrant and SAMHSA had partnered to provide some model legislation to every state. And that was tracked really on a weekly basis through the crisis jams, which if you're not aware of the crisis jam, I would say Google the crisis jam, because that's a great in the know place for developments. So because our legislature knew in 21 that 988 was going live and that they weren't going to meet again until 23, they actually passed this legislation. And it was, again, a Democratic held legislature, but the governor was also Democratic. And so it passed pretty easily. But our sessions are really short, so they kind of push a lot of legislation through. So it's not uncommon that you need like a cleanup bill. So we thought this session, oh, okay, it'll just be a cleanup bill, but now we've got 2 bills competing. So, but that model legislation has been available for every state. A number of states have tried it. And what we try to talk about it, I use the T word, which is the tax word, but we talked about it as a fee, that it's a fee on your phone line, that in the same way, if you have your cell phone and you get in an emergency and you need to call 911 because you're in a car crash, if you're in a behavioral health or a mental health emergency, we want you to be able to call 988 and to have the support for that. And there was really resounding support for that. Everybody has a friend, a family, a neighbor, or they themselves have experienced like a crisis at some point. And so it really resonated with the legislators and with the public.
How much money has been saved since 988, since the implementation as a result of diverting people away to lower levels of care, as opposed to ERs and inpatient units and, you know, jails? Has California collected any data on this? This is obviously, you know, not an easy question to answer, but if we have any information to share.
Being that's the first year, as the 13 centers are really working at gathering that type of information, there is some information that we could potentially report out on. One of the things that we usually do is if it would be, for instance, instead of an active rescue, it was a top down. So everything was there, that the individual had the intent, means to act on either a suicide attempt or to take their lives at that time, and we were to de-escalate them. That's something that we could actually potentially calculate out based upon how much it would cost for an ER visit to deploy EMS or law enforcement. We still don't have those numbers. I could give you center specific or send it over to Danielle for what we've seen here and try to get that up. But it's still, we're still a long ways to go on how we can actually gather and report out on all that type of data. So unfortunately, I don't have a clear number for you at this time.
It is a difficult question to answer because there's the diverting people from higher levels of care, but then there's probably more people accessing services than would otherwise too. For example, like if you look at like the first 5 years or so of the Crisis Response Center in Tucson being open, law enforcement drop-offs can like steadily increased. And I think over 5 years, it was like a 35% increase, if I remember right. And if you talk to them, they're bringing people that they wouldn't otherwise in the past have brought anywhere because, you know, they didn't really have a place to bring them and they couldn't take them against their will to the ER. They kind of were in this sort of middle category. And those people may have later had a crisis that escalated, but it's hard to measure that. That said, though, if you just look at crisis utilization and you look at people accessing phones and people accessing mobile and people accessing the facilities, you can extrapolate, you can compare the cost of that to if they had gone to an ED, if they had gone to a hospital. And there's been some studies of the Arizona system. There's some white papers on the NASHPD website that have some of those in there. Also, too, the cost of all of this, and we're working on a research study also that hopefully will be done soon using access claims, but there's other areas of savings too. So you can look at in many communities, if police bring someone to the emergency room, they have to wait with that person for hours often. And so with the Arizona data, there's been extrapolations of turning that back into FTEs of officers back on the street. We were consulting years back with Nashville, and they actually got money from the city because they were able to say, this is how many FTEs of officer back on the street this could, you know, be translated into. And then you can look at jail booking fees and things like that. So it's a really complex question, but so I don't know if how well that answers your question, but there's a lot of research going on trying to have better ways to answer that.
The data and the numbers still kind of being figured out, and it might not be something we see right away, or and Liz, you're right. I'm glad to hear that everyone is collecting data and using data to make more decisions and planning purposes. I mean, that's really how we should be doing things when we're working in the community and we're providing services. I think each and every one of you talked a little bit about like kind of the workforce challenges we're seeing across and here in California, across the nation. What are any hiring trends, things that you're seeing that are really working when looking for team members for these call centers, crisis lines?
I would say when building or strengthening your relationships with colleges, universities, or other like service type providers in the community, that has really helped kind of create like a funnel point where I can bring people in. We can bring them in on it as interns and then potentially hire them. That's helped out. Another thing that has worked is when we're just going out to different agencies, like through our outreach, like, hey, we're actively recruiting. So some of that word to mouth and internal hires of people that are existing from the team members, like asking if they know anyone who they would feel would be a good fit for it. That would be some of our successes so far, because it is challenging work and it's really hard to get someone that wants to work nights and weekends and overnights. And anyone in this room could speak to that knows that's one of our biggest challenges. And then we really want to bring in people that have like the heart to do the work. So for us, like, you want to get someone that's going to not only be a good fit, but ultimately be a good service to the people that need this service. So, finding those good-hearted people, finding is hard. And that's an ongoing search I think anyone can attest to, and any other viewpoints, I'd welcome them.
Thank you, David, for sharing. Erin mentioned that they reached out to the university in an attempt to secure a contracted licensed mental health practitioner. And I've heard other programs and counties here in California doing the same, really using that partnership and collaboration with universities to develop that kind of that link between new grads or even interns into this kind of work. And so thank you for sharing.
I was just gonna say, I know that there have been a lot of creative and very innovative hiring things going on here in Arizona, but at the level and the structure of our state, that's really done at the call centers, at the mobile team provider level. From what my understanding is just basically what David said. Really, you can get applicants in, but it's getting applicants that want to do the work and want to stay and want to do whatever it takes, including those awkward shifts. It's never fun to take a crisis call. Dr. Balfour will tell you, as someone who was surprised by one. But I think what we've seen work really well is retention efforts, really taking the time to debrief with our crisis counselors and our mobile team staff and the stabilization facilities. When they interact with something that could be traumatizing to them as staff, taking the time to slow down and say, yes, we're serving hundreds of people and we're doing it at a very fast pace, but we need to serve the people that are serving those people, right? And so, we've seen a lot more effort go into just, again, staff debriefs and employee appreciation to work on that retention piece. And then the staff will call their friends. That's what we've learned here in Arizona. If you provide a good working environment and you take care of people who want to do this work, they know who else is looking for a job that will stay with you. So a big piece of the workforce challenge is not just getting them, but keeping them and asking them for help in finding people that are like them, that are willing to do the work.
Yeah, and in that vein, one thing we've worked on at our organization is to try to build in more career ladders so that there's an opportunity for advancement. We've had people who've started off as peers, moved into other roles within each individual discipline, like our case managers, techs, et cetera, trying to build levels so that you can advance within your discipline. So that, because so many people come into the public system, they, right out of school, they get a bunch of experience and then they go off somewhere else. And we want to, how can we have people feel that they have the opportunity to advance within our organization versus having to go?
Thank you all again. We had a great session here, packed with so much information and knowledge. Really appreciate it.